Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clearnet, serving as the allocator session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clearnet serves as a digital partner for this event, and the focus of today's session is inotropic support. Now, I would like to invite Dr. L. Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including the Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council member, President and State Secretary of the ISA Tamil Nadu State Branch. To proceed with the session, over to you, sir.
Thank you very much. At the outset, I request our President, Dr. Munian, to offer his presidential address.
Good evening, all, sir. Today, I am very happy to see such a great persons in our online webinar. Every week, we are conducting online webinar in the name of Puthukkottai Bhudhan. Today, we are conducting 18th episode of second edition in the topic of inotropic support. Myself and some younger anesthesiologists are very much eager to watch your speeches, sir. Honorable moderators, esteemed colleagues, and fellow professionals, I am honored to address the critical role of inotropic support in our day-to-day practice, like shock and other cardiac failures. As we are the reputed anesthesiologists, we must understand and ensure the safe and effective method of administration of inotropes. There are three principles available. One is cardiac functions, and another one is the hemodynamic monitoring and titration of the inotropic support. Careful titration of the inotropic support is very much essential for optimal health, for optimal effects. Inotropic supports and their uses. Dobutamine, which increase the heart rate and the cardiac contractility, and dopamine, epinephrine, and milrinone, which all increase the heart rate, cardiac contractility, and also increase the cardiac pressures. What are the clinical considerations where we need inotropic supports like cardiac failure, shock, and monitoring? Close monitoring of the hemodynamic support like ECG, clinical response are essentials. What are the basic practices where we need inotropic supports like which needs individualized therapy? Tailoring inotropic support to individual patients need is crucial. Dose and titration, careful dose and titration is very much effect while minimizing the adverse effect of the inotropic drugs. Inotropic support needs multi-disciplinary approach where needs a collaboration with the cardiologist, critical care physicians, and all. By understanding the basic principles and best practice of inotropic support, we can optimize the patient's outcomes and improve our cardiac care. Today, we are gathering online webinar in the topic of inotropic support, and our speakers are very much interested to share their great experience with all of us. Thank you, sir.
Thank you, Mr. President. I request our Secretary, Dr. Kannan, to offer his Secretary report.
Good evening, all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 18th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is inotropic support. I welcome all our eminent speakers to our webinar. I welcome all the delegates participating in the webinar. Last week, 14th May, we have conducted 17th webinar of second edition of Puthukkottai Bhudhan very smoothly. Last week topic was intravenous fluid therapy. We have divided the topic into three subtopics. First one is physiology of fluids. Second one is clinical significance of various fluids. Third subtopic is perioperative fluid therapy. Our moderator was Dr. Samsad Begum, Professor and HOD, MS Medical College, Kerala. First subtopic, physiology of fluids, was done by Dr. Vijitha Suresh, President, MS Medical College, Kerala. Second subtopic, clinical significance of various fluids, done by Dr. Anjali Rajan, Assistant Professor, MES Medical College. Third subtopic, perioperative fluid therapy, was done by Dr. Asita, Assistant Professor, MES Medical College, Kerala. Last week, webinar was attended by 922 delegates. Academic faculties, kindly encourage your postgraduates to attend our webinar continuously, which are very helpful in their exams. One more important thing, we are going to conduct workshop on ultrasound guided nerve blocks and CME on June 14th and 15th at Emigrant Hotel, Puthukkottai. We request all the delegates to attend our CME. Thank you, sir.
Thank you, Mr. Secretary. Now it is my duty to introduce the faculty in my thematic address. Today I am really very happy because I want to inform all the attendees that we are having the great faculty this time. Every time we have it like that. But usually the government medical college faculty will be there. But as you all know, in the specialty surgery, especially in cardiothoracic, only the private participation is more and they dominate. So in this time, the three speakers, that postgraduate is from a government private medical college, and all the three are from great hospitals because it's a multi-crore project hospitals they are working, like Dr. P.S.N. Raju in Apollo Vanagaram, Dr. Subhendhu Sarkar in Desun Hospital, and Dr. Muralidha sir in Narayana Hrudhalaya. All are multiple crore hospital project, and they have even for cardiac they have 6 to 20 theaters. So such a big institutions they are managing, and these people are ready to spend their time for the youngsters. That too, a city branch is organizing a continuous webinar, and they really support our cause. So I bow my head and thank the legends in cardiac anesthesiology. That is a great thing because cardiac anesthesia is now having a separate society, and these people are top ranking officials in this. These three, they know each other, they know their value because minimum 5,000 cases they have anesthetized in cardiac surgery, and the maximum is 20,000 cardiac surgeries they have anesthetized. So daily they are doing 6 to 8 cardiac surgeries, and they are good at various topics, and they know the nuances of cardiac anesthesia. Like when they talk in conference, they will talk about the modalities of managing congenital cardiac shunts and what are the role of nitroprusside, aminophylline, so many things, intricacies. But for us, they want to discuss about the practical point, inotropic support. So I thank them for having accepted our request. And the youngest speaker is Balaji Chenthil. Again, Dr. Parthsarthi used to introduce the new faculty whenever we ask for support. And Dr. Balaji is the youngest faculty today as a postgraduate. And he is from Mahatma Gandhi Medical College, Puducherry. And see, he is a topper in biochemistry. He is a topper in biochemistry, and he is married. His extracurricular activities are swimming. So I used to say, anesthesiology is just like swimming. You can practice breaststroke or backhand stroke or whatever it may be. You have to reach the shore safely. And he is a good swimmer. So whatever may be the technique, he will reach the shore safely. So you practice regional anesthesia or general or nerve block, whatever it is, you have to safeguard the patient. So Dr. Balaji is already a great swimmer. So he will swim the field of anesthesiology, and in due course, he will be the future P.S.N. Raju or Muralidha sir or Subhendhu Sarkar. We wish him all the very best. And it will be followed by Dr. P.S.N. Raju, who is going to deliver a lecture on pharmacological inotropic support. And he is such a great personality. He is, even though he is a great personality, all the three people are down-to-earth people. They mingle with us like our school friend or college friend. And I had one full day with Dr. P.S.N. Raju in Andhra Pradesh, Rajahmundry. And he was such a great speaker. He was talking about ECG. Very basics. Even I said with his knowledge, we can perform very well. He is a very quiet person, and he is from Andhra basically. He did his MBBS and MD in Rangaraya Medical College, and he is a university first ranker in forensic medicine. Anybody knows that he is a university first rank in forensic medicine. And another peculiar point is he has won a gold medal in general surgery, but he has taken up anesthesiology. He has won a gold medal in general surgery, but he wanted to use his brain for anesthesiology. So he has joined anesthesiology and he has worked 30 continuous years in anesthesiology. And he was the first one to assist the multi-organ transplant. And he has trained the anesthesiologist in Sri Lanka. He has visited Australia, Netherlands, England, Belgium, every area just to observe what is happening there. And he is introducing everything in Tamil Nadu, Chennai. We know him as a Vijaya Hospital anesthetist because he started his career in Vijaya Hospital only. Then he has switched over to Apollo Hospital in 2014. To his credit, he would have anesthetized minimum 20,000 cases. And as he is working in a specialty block, in addition to cardiac anesthesiology, he is taking up cases in plastic surgery, neurosurgery. So all specialty surgeries he is doing. And he's one of the pioneers in Indian Association of Cardiovascular and Thoracic Anesthesiologist. Even I am also a member, just a member only. Once I attended and I left. But all these three people are key people in that association, Indian Association of Cardiovascular and Thoracic Anesthesiologist. The sir was the treasurer, he was the president. He has won that oration award also in Indian Association of Cardiovascular and Thoracic Anesthesiologist. In spite of his all the busy schedule, he is interested in reading books. Books means it is not just books. He is reading only economic books to boost his economy. Anesthetists are very poor in earning, but he knows how to earn and how to safeguard the money. So not only he is reading economic books, even his news channel is interested in business news channel. So he is the topmost person in that, and even his school days and college days, he has won quiz competitions. So he is a great general knowledge person because I talked to him in Rajahmundry. He knows the entire history of Rajahmundry and the passage of Godavari River. Even Godavari might have forgotten what route has to take, but he knows everything from the ancestors part. He is telling everything. So I thank Dr. P.S. and Raju for accepting our invitation. It will be followed by, see, if you say Sarkar, we know only P.C. Sarkar, the magician. So he is the cardiac magician. I know he's a second Sarkar. Only two Sarkars I know. One is P.C. Sarkar. I have seen his shows also. So this man's show is tremendous because he is noted as a ECMO physician. So that is a great thing. Subhendhu has won a gold medal in MD exam. So he has won COPS National Award in ISACON. He has won Janak Mehta Award. So he has participated and won awards in ISACON as well as Indian Association of Cardiovascular, their own association. So he is the founder secretary of the West Bengal branch of Indian Society of Intensive Care and Perioperative Medicine. That is a good thing because anesthesiology has to be redesignated as perioperative medicine, and he has taken a step. And naturally, as he has dedicated his life for cardiac anesthesiology, he is a certified BLS and ACLS instructor. And he has been a member in 13 medical associations. And he has organized the West Bengal, in West Bengal, Kolkata, he has arranged that national conference in anesthesiology, ISACON 2017. And because of his courtesy, I have tried golf. He has called that golf person as executive golf stadium, and he has announced if anybody is interested, they can try golf. Even I am the only one who used that opportunity because of Subhendhu Sarkar. So I thank for him, and he has arranged 2 state level conference, 2 zonal conference, and 1 national conference. And in addition, I want to mention this only because the great people, they find how to utilize the time. They don't say that we are not having enough time. So in spite of his natural intelligence, Dr. Subhendhu Sarkar is interested in artificial intelligence. So both goes together, and he is interested in Ravindra Sangeet, and he is a passion in about driving. So now he is going to drive into our brain his knowledge which he has acquired all these years, and he is interested in watching movies also. In addition, he is a motivational speaker. You should note that. So now he is going to motivate us how to use ionotropes in cardiac support. And I have to mention one thing about P.S.N. Raju. When I designed the flyer, I mentioned pharmacological support for P.S.N. Raju and mechanical support for Dr. Subhendhu Sarkar. Mechanical inotropic support I mentioned, and Dr. P.S.N. Raju corrected it as circulatory support. So that is the reason why they are labeled as cardiac anesthesiologists. Then I was really worried when two legends are coming. Almost they have dedicated their life 30 years minimum in cardiac anesthesiology. Who is going to moderate the session? So immediately Dr. Muralidha Kanchi from Narayana Hrudhalaya came to my mind. So he is a topmost person in cardiac anesthesiology. Again, he is down to earth person. I am happy he knows Tamil very well. He knows Tamil very well. And Sir is a director, academic, Narayana Health City. And he is a professor and a senior consultant in anesthesia and critical care. So we used to say educated people will be respected everywhere. So he is a professor of international health, University of Minnesota, USA. So he is respected even in foreign countries, and he is a principal Narayana Hrudhalaya and Allied Health Sciences. So he is interested in cardiac anesthesia, and his papers are enormous. Everybody, they are good at publishing research papers in conferences. And Sir is interested in cardiac anesthesia and TEE. Everybody should go and visit Narayana Hrudhalaya, such a great hospital for cardiac setup. And Sir has national and international publications. Can you imagine how many he has? It is 120. It is 120. And that is the reason why he is leading in the cardiac anesthesiology. And Sir has won Rukmini Pandit Award. And he is a professional of international health in Minnesota from 1999. And he is a course director for National TEE workshop. And he is a PhD graduate from Maastricht University, Netherlands. This and all simple, cardiac. For him, it is very simple. But in spite of all these achievements, he is a great singer. He's a great singer. He's a Veena player. Don't think that it just he is a singer in the bathroom. He is a Carnatic learned singer. He has participated in Thiruvayaru Music Festival in Tamil Nadu. It is near Tanjavur only, Thiruvayaru. So Thiruvayaru, whatever may be the great personality, they will be given only 15 minutes time. So even with that Carnatic musicians, a doctor has participated, the two anesthesiologist is respected in that Carnatic music, and he has participated in Thiruvarur also. So all music festivals, Sir is taking part. That means he is respected by musicians in the music field and by anesthesiologists in the anesthesiology field. So I thank Sir for having accepted our request. And again, we want to remind on June 14th and 15th, we are going to conduct a ultrasound guided nerve block workshop and a CME on various topics. Across the country, faculties are taking part in Puthukkottai. Thank you very much, sir. Now over to Dr. Muralidhar, sir.
Good evening and welcome to this ISA Puthukkottai City Branch weekly anesthesia webinar. Thank you for the invitation, and I value this role given to me very much. And thank you once again, Dr. Meenakshi Sundaram. Dr. Meenakshi has introduced Dr. P.S.N. Raju, Dr. Subhendhu, and me. And thank you so much for your kind words. And I come to know that this is one of the most successful webinars in the world, I would say, with attendance of reaching 1,000 per session is something unheard of. And I congratulate Dr. Meenakshi for this incredible feat, I should say. With that, without wasting much time, today's topic is inotropic support. And we have three speakers. One will be touching upon the basics of cardiac output, followed by pharmacological treatment of heart failure, especially in terms of low cardiac output syndrome. And then we go on to the mechanical support. And we are looking forward to the deliberations. So with this, I would like to invite Dr. Balaji to talk about factors which affect the cardiac output. Very important topic. And I request all the participants to keep the mics muted till the end of the session, excepting the speaker, such that the audio quality is maintained, and you can post your questions in the chat box. We'll address it at the end of the session. With that, I would like to request Dr. Balaji to make his presentation on factors affecting cardiac output. Thank you once again.
Thank you, sir. Good evening, all. Hello, sir. Good evening, all. I would like to thank Dr. Parthasarathi, sir, and Dr. A.L. Meenakshi Sundaram, sir, for giving me a great opportunity to speak on the largest online platform, Puthukkottai Bhudhan, and in front of great giants in anesthesiologists. Today's my topic on presentation is factors affecting cardiac output. What is cardiac output? It is the volume ejected by the left ventricle to the aorta and thus to the rest of the body. Cardiac output is the amount of blood the heart pumps in 1 minute. It is the values, it is usually for males, it is 5 to 6 liters per minute. And for females, it is 4 to 4.75 liters per minute, and it may be less. And for children at birth, it is 350 ml per kg per minute. And after 1 week of birth, it comes to 150 to 200 ml per kg per minute. Cardiac index is 3 to 3.2 liters per minute per meter square. And cardiac output is the same for left ventricle and right ventricle. Basically, cardiac output is heart rate into stroke volume. For example, if a person is having 70 ml of stroke volume and heart rate of 70 per minute, then it equals to 4,900 ml, approximately 5 liters per minute. What factors affects the stroke volume? Stroke volume depends on the preload, contractility, and afterload. Preload. Preload is the ventricular load at the end of the diastole before the contraction has started. And the permissive role of the heart is, we need to know about the Frank-Starling relationship is an intrinsic property of the myocardium by which stretching of the myocardial sarcomere results in enhanced myocardial performance for subsequent contraction. The cardiac output it can go up to 13 to 15 liters per minute, and it decreases in the heart diseases. The cardiac output is increased in exercise and athlete. It is equal to, it is compared to the catapult. The more the left ventricular stroke volume is there, the more the contraction and the ejection of the blood from the left ventricle. This is the simple, this is the Frank-Starling relationship in various states. In normal, the left ventricular end diastolic volume, which causes myocardial stretch, and it causes equal ventricular performance, and it causes the ejection of the blood from the left ventricle. In cases of heart failure and fatal myocardium depression, the myocardial stretch will be more, but the ventricular performance will be lesser. In clinically, we can't measure the left ventricular end diastolic volume or the preload. So by clinically, we can measure by measuring the CVP. This denotes left ventricular end diastolic volume is directly proportional to the left ventricular end diastolic pressure, provided the ventricular compliance is normal. The left ventricular end diastolic pressure is directly proportional to left atrial pressure, provided the mitral valve is normal. Left atrial pressure is directly proportional to the pulmonary artery occlusion pressure or wedge pressure. The pulmonary artery occlusion pressure is directly proportional to pulmonary artery end diastolic pressure, provided pulmonary vascular resistance is normal. Pulmonary artery end diastolic pressure is directly proportional to right atrial pressure, provided tricuspid valve is normal. So clinically, the preload is measured by measuring the central venous pressure by securing a central line which directly measures the right atrial pressure, and it measures the preload of the heart. Preload may decrease in cases of bleeding RTA and obstruction to the large veins and sudden dilation of the peripheral veins. This is a pictorial diagram. We can compare the heart by comparing a cyclist. The preload will be the wind that is pushing the cycle, and the contractility of the heart, it is the bicycler who is flexing his muscle and moves the cycle faster, and the afterload is the bumps it is in the road. Force of contraction, cardiac contraction. Clearly, if the cyclist flexes his or her muscles a little and pushes harder on the pedals, then the bicycle will move faster. This can be equated to an increased contractility of the heart muscle, resulting in increased cardiac output. The contractility of the heart is the intrinsic property of the heart. The contractility of the heart does not depend on the preload of the heart and afterload of the heart. It is the intrinsic property of the cardiac muscle. Factors increasing the contractility: sympathetic stimulation or parasympathetic inhibition and administration of positive inotropic drugs such as digitalis. Factors decreasing the contractility: parasympathetic stimulation or sympathetic inhibition via blockade of adrenergic receptors or administration of beta adrenergic blocking drugs, slow calcium channel blockers, myocardial ischemia and infarction, intrinsic myocardial diseases such as cardiomyopathies, hypoxia, and acidosis. As the long distance cyclists will know, prolonged strenuous exercise can lead to high tissue oxygen demands, which can later result in impaired muscle contraction and poor performance. So in continuous prolonged inotropic support, it causes mismatch of the oxygen demand supply, which eventually causes cardiac failure. So inotrope should be used cautiously. Afterload. Afterload is the systolic load on the LV after the contraction has begun. By applying the Laplace law, the afterload is the wall stress. Wall stress is equal to the pressure into radius of the ventricle divided by 2 into wall thickness. So in the case of chronic hypertension or uncontrolled hypertension, to lower the wall stress, the wall thickness has been increased. So in cases of chronic hypertension, uncontrolled hypertension, there will be a LVH for reducing the wall stress. Afterload. How does it feel to cycle downhill? This is what vasodilators do to decrease the afterload. So for ideal heart to function and push the pedal faster, also make the road less bumpy and smooth. Sometimes we need both, like inodilators like milrinone, levosimentan, dobutamine. Cardiac output is also depends on the heart rate. Heart rate depends on cardiac conduction system, central nervous system, autonomic nervous system. There should be a sinus rhythm to have adequate cardiac output. So blood pressure is nothing but cardiac output into systemic vascular resistance. Factors affecting heart rate, it is based on the autonomic innervation, hormones, fitness levels, and age. Factors affecting the stroke volume, preload, afterload, contractility of the heart, fitness levels, and gender. So cardiac output is equal to heart rate into stroke volume. So this is the final schematic diagram of my presentation. So stroke volume into heart rate is equal to cardiac output. Stroke volume depends on the preload, contractility, and afterload. Preload depends on the venous return and muscle pump, blood volume, respiratory pump, gravity, and valves. Contractility, it is based on the IANS and CNS system. So cardiac output into peripheral vascular resistance is equals to arterial pressure. Arterial pressure is sensed by the carotid and aortic pressure receptors, and it sends its signals to medullary, vasomotor, and cardiac centers, which influences the cardiac output. So as the simple way to assess the cardiac output is measuring the urine output. It should be minimum 0.5 ml per kg per hour. This means the cardiac output of a patient is normal. Thank you, sir.
Thank you very much, Balaji, for that clear-cut presentation on the factors which affect the cardiac output. You started with defining what is cardiac output and then went on to the Frank-Starling relationship, and you also mentioned about the role of each factor which affects the cardiac output, that is preload, afterload, contractility, and heart rate. And also you mentioned about the relationship between the end-diastolic volume and pressure, how it may be equated to the right atrial pressure if everything else is normal. Thank you for that presentation. Please stay
Thank
back till the end of the session
Yes.
so that if there are any questions, we can address them.
Yes, sir.
It
Thank
is
you, sir.
now it's my pleasant duty to invite Dr. P.S.N. Raju, who is very well known cardiac anesthesiologist, is anesthesiologist par excellence in cardiac field, and is highly respected for right reasons. And we are looking forward to his presentation on pharmacological support of the failing heart. Dr. P.S.N. Raju.
Thank you, Dr. Meenakshi Sundaram, for inviting me for this wonderful webinar. You're doing a wonderful work for teaching the postgraduates. We are always happy to be participating in this such type of activities. Thank you, Dr. Muralidha, for accepting to be the moderator for this session. It's a great pleasure having you, eminent anesthesiologist like you, moderating this session. So my topic is about the inotropes. I slightly changed the topic because all of us know there are a lot of inotropes available, and how to choose inotrope is always a question for the practitioners and postgraduates. So I thought I'll simplify the topic and make it, I'll just be talking about the basics of inotropes, how they act, and how to choose a right inotrope in a particular situation. So in this next 30 minutes or so, I'll be covering what is an inotrope, what are the indications for inotrope, what are all the available inotropes, how do they act, and which one is the best. So as my previous speaker has nicely explained, inotropy is a condition of contractility of the myocardium. And inotropes are the substances that increase the force of energy of the myocardial contraction. He has already mentioned about what are the factors affecting the cardiac output. To review, is the heart rate, rhythm, preload, contractility, and afterload. These are the 5 important factors which decide the cardiac output, which determine the cardiac output. Before going into the inotropes, I also, because we tend to use these words something for each other, so we should know the other terminologies. One is called chronotrope. Chronotropes are the agents which increase the heart rate. For example, isoprene is a chronotrope, but other inotropes also increase the heart rate. So they also have got some chronotropic action. Many of the inotropes also have a chronotropic action. Coming to pure inotropes, which improve the myocardial contractility, the examples are dopamine, dopamine, adrenaline, milrinone, and levosimendan. And also we tend to mix the inotropes with the vasopressors also. Strictly speaking, vasopressors are not inotropes. They are cardiac, they act on the circulation, they increase the afterload, and they improve the perfusion pressure. Examples are noradrenaline and vasopressin. But some of the inotropes also increase the afterload if you use them in higher doses. So we tend to interchange the words, but in strict terminology, inotropes are the ones which increase the myocardial contractility. They may have some chronotropic action, and at higher doses, they may also act as vasopressors. After this introduction, I will go into what are the available inotropes. We all know the available inotropes currently in our country are dopamine, dobutamine, epinephrine, norepinephrine. Of course, it's a vasopressor. PDE3 inhibitors, phosphodiesterase 3 inhibitors, that's milrinone. And then another novel inotropic agent, that is the levosimendan. So these are all the agents available for us. So what are the indications for inotropic support? Most common indication and most important indication for inotropic support is a cardiogenic shock. It may be secondary to mostly to acute myocardial infarction or a resultant of a low cardiac output syndrome from a post cardiac surgery and other scenarios also. Also sometimes when there is a acute MR or acute mechanical defects also, the patient can go into a cardiogenic shock. Other thing is a congestive heart failure or a decompensated heart failure. Here also, we need inotropic support to maintain the cardiac output. Other indication is post-cardiac arrest. After cardiac arrest, even after reviving, many a times we need inotropes to continue the cardiac output, to improve the cardiac output. And post-operative cardiac patients, sometimes even cardiac patients undergoing non-cardiac surgery also will need inotropic support. In septic shock, there is mostly vasodilatation. They will need more of vasopressors. But sometimes in septic shock also, there will be myocardial depression. There you will need inotropic support. Anaphylaxis also, you will need sometimes inotropic support. Vasoplegia, which may be secondary to septic shock, sepsis, or a part of the MODS, or sometimes even usage of agents like ACE inhibitors and ARBs also, the patient can go into vasoplegia. Here also, you will need mostly the vasopressors like noradrenaline or vasopressin. And also patients with chronic heart failure who are candidates for bridge to transplant or mechanical support, they also will need inotropic support. So these are the a few conditions, common conditions where inotropes are used. Apart from this, there are a lot more conditions where we do use inotropic support. For example, during procedures in the cath lab, during primary angioplasties, also we use the inotropic support. So in perioperative period, why do we need inotropes? To maintain an adequate oxygen balance is one of the primary causes why we need, especially when cardiac patients are undergoing cardiac surgery or non-cardiac surgery. In the post-operative period, we need to maintain an adequate oxygen balance. So we need inotropes. And all of you know that cardiac output is the important component for delivery, oxygen delivery to the tissues. And inotropes increase the cardiac output, and also they may increase the mean arterial pressure, and they improve the perfusion to the vital organs and tissues. So apart from the benefits of inotropes, there are also some risks associated. The main benefits are inotropes improve the cardiac performance, they improve the contractility of the myocardium, and many times they may increase the blood pressure, but sometimes blood pressure may come down, but tissue perfusion improves. To increase the mean arterial pressure, sometimes we may have to use a vasopressor along with the inotropes or inodilators. But there are certain risks associated with the inotropes. That is, many of them cause increase in heart rate, and that can cause deterioration of the failing heart. That is called flogging of the failing heart. Like if the heart is already weak and it is failing, when you give more inotropes, it can fail faster. That is where the role of mechanical circulatory support will come, which my next speaker, Dr. Subhendhu Sarkar, will be covering. And it also increases the myocardial oxygen demand, because for increasing the contractility, the myocardium itself will need more oxygen supply. So if you use excess inotropes, sometimes, especially during acute myocardial infarction and all, it can be deleterious to the heart. And inotropes also, especially at higher doses or unindicated, they can cause arrhythmias. So we should keep in mind when we are choosing inotrope these risks also. So, mechanism of action of inotropes. All these agents, they increase the force of myocardial contraction. My previous speaker has told in detail about it. They do by increasing the cytosolic calcium concentration. This calcium will promote actin-myosin cross-bridge formation, and which leads to myocyte shortening and the contraction of the myofibrils. So that will generate the cardiac output. That will improve the cardiac output. And what are the various mechanism of action? See, different inotropes, they act at different receptors, like the what we call commonly catecholamines, that is the dopamine, dopamine, adrenaline, and adrenaline. They act at the receptor level, beta receptor, and they act on the ATP cyclic AMP pathway, which will lead to improvement in the contractility. Whereas the phosphodiesterase 3 inhibitors, they inhibit the degradation of cyclic AMP into inactive AMP. The example is milrinone. Amrinone is currently not available. It used to be available in early 90s. Currently, this group of what is available is milrinone. And the other group is the levosimendan, which is a calcium sensitizer. It acts at this level. So that will lead to, so these are the different mechanisms by which the inotropes act on the myocardium. So there are various classifications of inotropes depending on where they act, how they act and all. There is another simple classification of inotrope. They are classified into adrenergic and non-adrenergic classes. In adrenergic, there is called catecholamines and non-catecholamines. In catecholamines, there are natural. Examples are natural catecholamines are adrenaline, noradrenaline, and dopamine. Whereas sympathetic catecholamines, examples are dobutamine, dopexamine, and isoprolane. Coming to non-catecholamines, direct acting, or we know phenylephrine, it increases the SVR and improves the mean arterial pressure. Indirect acting ephedrine also can act like a very mild inotropic action. Whereas coming to the non-adrenergic inotropes, the important group is the PDE3 inhibitors, that is phosphodiesterase 3 inhibitors. Amrinone, I said, is the first generation. It is not currently available. Milrinone is available in our country, and we use quite frequently in the post-cardiac surgery scenarios. And other miscellaneous agents which act as inotropic, which have got some positive inotropic action, is one is digoxin, and other one is the calcium. Calcium also can act as a inotrope when we inject it. Coming to the pharmacology, as I already mentioned, there are various receptors, and various agents will act on these receptors. For example, if you take dopamine at higher doses acts on the alpha receptors, and it increases the systemic vascular resistance, and it increases the blood pressure also. It increases the afterload. It has got mild action on the beta-1 receptors. It is a milder inotrope, but its prominent action is also on dopamine receptors. Whereas dobutamine acts on the beta-1 receptors, and mostly on the beta-1 receptors, and it also has a mild action on the alpha receptors. Whereas norepinephrine, if you take, it acts predominantly on the alpha receptors. That's how it increases the SVR, it increases the mean arterial pressure, and it has got very, very mild or insignificant action on the other receptors. Whereas if you take epinephrine, which has got a more broad spectrum, it acts on the beta-1 receptors, it acts on the beta-2 receptors. At higher doses, it also acts on the alpha receptors. So adrenaline is a very broad spectrum inotrope, which also acts as a vasopressor at a higher doses. Whereas at moderate doses, it acts as a inotrope. Whereas phenylephrine, it predominantly acts on the alpha receptor. It purely increases the blood pressure. It increases the systemic vascular resistance. Whereas vasopressin, it acts on the vasopressin receptors, which also leads to increase in SVR, increase in the mean arterial pressure. Now coming to individual inotropes, as I already mentioned, epinephrine is a naturally occurring inotrope, that's a catecholamine, and it acts both on the alpha and beta receptors. And it is, in the usual doses, we use the beta adrenergic effects on the heart and vascular smooth muscle will predominate. At higher doses, the alpha adrenergic effects will predominate. The common dose used is about 0.5 microgram, 0.5 to 0.05 to 0.5 microgram per kg per minute. These are all given in infusions, diluted, usually given through syringe pumps. They are nowadays not given in bottles, or now syringe pumps are available in most of the hospitals, and it is safer always to dilute them and put them in a syringe pump and give it as per the recommended doses. Other effects, once you start a adrenaline infusion, you can see clearly there will be increased blood pressure, there will be increased heart rate, and it also acts on the bronchial smooth muscle, leads to reduction in the status asthmaticus like condition. It causes vasoconstriction of the peripheral blood vessels. That is where the blood pressure goes up. Other thing is adrenaline also, epinephrine is our other name. We always call it also as adrenaline. It increases the blood glucose levels, lactate. It has got metabolic effects. That is where sometimes can be deleterious. Once you start a epinephrine infusion, the blood glucose levels go up significantly. The lactate levels go up significantly. And there are also certain side effects for adrenaline. It causes tachycardia, it is arrhythmogenic, and it can worsen the myocardial ischemia. And it also reduces the renal blood flow and also the glomerular filtration rate. It increases, I already mentioned, blood glucose levels, and it can cause also restlessness, anxiety, and tremor also. So when, especially in acute myocardial ischemia, that is during MI, acute MI, we should be careful in using adrenaline because it can worsen the situation. It can cause arrhythmias, it can cause tachycardia, it can worsen the myocardial ischemia. So coming to next agent, that is a commonly used agent, that is dopamine. Dopamine acts on dopaminergic receptors and beta 1 and beta 2 receptors, and also on the alpha receptors depending on the dose administered. It is not a strong inotrope. It is a mild. It has got mild inotropic dose and action at lower doses. But when we use at higher doses, they can cause tachyarrhythmias and act on mostly on the alpha receptors. So it's not that much preferred inotrope nowadays, dopamine. As I mentioned, it has got various actions at different doses. At the dose below 3 micrograms per kg per minute, it acts on the dopaminergic receptors. It can improve the visceral circulation. And in the doses around 5 micrograms per kg per minute, it acts on the beta receptors and improves the cardiac output, where it has got the, in this dosage, it has got the inotropic action. Whereas if you go to 10 micrograms per kg per minute, it the predominant action is on the alpha receptors and causes a rise in SVR, and it can also lead to tachycardia. Coming to next agent, which is a most preferred inotrope, that is the and also considered as a first line of inotrope, that is dobutamine. It is a synthetic catecholamine. It acts on the predominantly on the beta 1 and also on the beta 2 mild on alpha receptor. It contains a mixture of stereoisomers. The action is it improves the myocardial contractility. It also causes vasodilatation. This is a inodilator group of drug. It increases the heart rate, especially at higher doses. It increases cardiac output. The predominant increases the cardiac output, decreases the systemic vascular resistance. In the usual doses we use, there is a minimal effect on the heart rate. It decreases the pulmonary vascular resistance also. That is where it is useful in right heart failure also. So it is one of the most preferred inotrope, the dobutamine, considered as a first line of inotrope. It is useful in treatment of low cardiac output syndromes caused by myocardial dysfunction secondary to acute MI, in cardiomyopathies, and also post-cardiac surgery also it is used. And the advantage is it also causes diastolic relaxation and is useful in diastolic failure also, diastolic dysfunction also. Dobutamine is useful. And coming to the side effects, it can cause hypotension, and sometimes it may have, we have to use a vasopressor like a noradrenaline along with dobutamine to sustain the perfusion pressure. And it can increase myocardial oxygen consumption and can cause arrhythmias at a higher dosage. The common dose used is about 2 to 10 micrograms, but can go up to 20 micrograms per kg per minute. All the doses I am mentioning of all these inotropes, when you give a saline pumps, they are all measured by microgram per kg per minute. Okay, and prolonged usage can lead to beta receptor downregulation if it is used for longer time. Okay. Coming to the next inotrope, that is, we always call it as a second line. If the dobutamine is not effective or we need extra inotrope, milrinone. Milrinone is another preferred inotrope, and as I mentioned, it belongs to the phosphodiesterase 3 inhibitor group, and it is a second generation. First generation is amrinone. It was available in early 90s, late 80s, early 90s. Now currently amrinone is not available. Milrinone is available very much in our country. And it increases the cyclic AMP by inhibiting the conversion of cyclic AMP to AMP. It improves the contractility, increases the diastolic relaxation. It has got a lucitropic action. It also relaxes the heart muscle, and it causes vasodilatation leading to decreased SVR. It reduces the systemic vascular resistance. So when you start milrinone alone, it may cause sometimes hypotension, which has to be countered by starting a vasopressor like noradrenaline. Usually the favored combination is milrinone along with noradrenaline. It also not only reduces SVR. See, the advantage is in a failing heart, when the SVR is reduced, that is afterload is reduced, the myocardial contractility improves, the workload on the left ventricle will come down. It also improves the myocardial oxygen consumption. It reduces the right atrial pressure. It reduces the left ventricular and diastolic pressure. It reduces the pulmonary vascular resistance. It reduces systemic vascular resistance. It reduces pulmonary vascular resistance. It also reduces the filling pressures. That means it unloads the heart. The mechanism of action, what is important about milrinone is it is independent of adrenergic receptors. So in a patient with congestive heart failure, there is a downregulation of adrenergic receptors. So the conventional catecholamines, that is adrenaline, dopamine and all, dobutamine, may not be effective in patients with congestive heart failure. So in those cases, milrinone is very, very effective. And its half-life can be prolonged in renal dysfunction. And as I already mentioned, it has to be many times used along with noradrenaline or with adrenaline also. It is very much useful in moderate to severe LV dysfunction with elevated end-diastolic pressures. The adverse effects, as I already mentioned, hypotension, especially with the loading dosage, and sometimes it can cause ectopic beats. The dosage is, loading dose is 50 micrograms per kg over 10 minutes, followed by an infusion of 0.375 micrograms per kg per minute. Coming to the next novel inotropic agent, that is levosimendan. It is available for last 20 years to my knowledge in India, 15 to 20 years. It has got a different type of action. It has got a dual mechanism of action. By one mechanism where there is a calcium sensitization, it improves cardiac contractility without concomitantly increasing the oxygen consumption. So it is very useful. It doesn't increase the myocardial oxygen demand. It also causes diastolic relaxation. The other action is potassium mediated ATP channel opening. By this effect, it results in arteriolar and venodilatation, improving the blood flow to the vital organs. Especially in a failing heart, inodilators are very much useful because they improve the contractility and then they reduce the afterload. Afterload is like the previous speaker mentioned, it's like a bumps. More so I call them as headwinds. Like aircraft is going this headwind. So it has to pump against the resistance of the blood vessels. So these inodilators will help in relaxing that, especially milrinone, levosimendan, and dobutamine have got a very good action. That is why they reduce the myocardial oxygen consumption. They improve the contractility of the LV, and they are very much useful in failing hearts. Coming to pharmacokinetics, it takes about onset of action 10 to 20 minutes with levosimendan. Duration, usually levosimendan is given for 24 hours as infusion, 24 to 48 hours. After 24 hours, once you stop also, it is a long-acting drug, so it acts after discontinuation of the infusion also. Some of the studies have shown the potentially cardioprotective action during cardiac ischemia also. It is excreted by liver. The dose is 6 to 12 micrograms over 10 minutes per kg over 10 minutes as infusion, followed by 0.005 to 0.2 micrograms per kg per minute as infusion. And this agent also, levosimendan also, can cause dose-related hypotension, especially when you give a loading dose. Here also we may have to use a vasopressor like noradrenaline to counter the hypotension. Because apart from, all of us were talking about cardiac output, apart from cardiac output, you also need a perfusion pressure for the end organ perfusion. So you have a great cardiac output, but you have a drop in perfusion pressure, which is not good for the vital organ perfusion. Coming to other agents, that is isoprelin. As I mentioned in the initial part of my talk, isoprelin is mostly, we call it as a chronotrope, even though it also has got an inotropic action. It is a synthetic catecholamine with pure beta activity. It increases heart rate, but it also increases the contractility. Another advantage with isoprelin is it also reduces the SVR and also the PVR, that is systemic vascular resistance and pulmonary vascular resistance also are reduced by isoprelin. Stroke volume is increased because they increase in there is increase in heart rate, and also there is a drop in systemic vascular resistance. It also acts as I already mentioned, as a pulmonary vasodilator, and it is also a good bronchodilator like adrenaline. Isoprelin is especially indicated in a resistant bradycardia. Even after giving atropine, if your heart rates are very low, as already my previous speaker has mentioned, the cardiac output is equivalent to stroke volume into heart rate. Already in a failing heart, the stroke volume will be less, and unless we increase the heart rate, we cannot produce adequate cardiac output. That is where we need to importance of heart rate. So if the heart rate is too low and it is not responding to conventional agent like atropine, we can start a small dose of isoprolol as infusion. It is also useful in heart block condition. Before we get a main treatment for heart blocks is AV blocks is a temporary pacing or a permanent pacing. But till we get that instituted, we can use temporarily isoprolol. And where we need faster heart rates, that is especially in pediatric patients, Dr. Muralidhar does a lot of pediatric work. We use in pediatric cardiac surgery in the in the perioperative period isoprolol, and also in transplant patients also we use isoprolol because the heart is denerved, the donor heart when it is taken out. So we have to use agents like isoprolol to increase the heart rate. And it is also useful in status asthmaticus, especially if there is a beta blocker overdosage also, as it is a pure beta 1 agonist, it is useful in overdosage of beta blockers also. It is also, isoprolol is also indicated in right ventricular failure. Main side effects are tachyarrhythmia, so we have to be careful, especially if we are using in a coronary artery disease patients. And it also causes vasodilatation and sometimes hypotension. The dose is 0.01 to 0.1 microgram per kg per minute. Coming to the other group of drugs which we use mostly along with inotropes or alone in case of shocks is are the vasopressors. I'm going to talk about two vasopressors which we commonly use. But I want the postgraduates to please distinguish between a inotrope and a vasopressor. Noradrenaline and vasopressin are not inotropes, they are vasopressors. Phenylephrine is also a pure vasopressor. So major difference between adrenaline and noradrenaline is that the alpha effects are very predominant in this with noradrenaline, even in the lower doses. It produces increase in SVR and it has got a very minimal effect on the beta receptors. Renal, hepatic and cerebral blood flow will be reduced if you use in high doses. So whenever we are using high dose of noradrenaline, we should monitor the SVR. If the SVR is very high, we should not be increasing the dose of noradrenaline. It also increases the systolic blood pressure, diastolic blood pressure, and also pulse pressure. It actually, noradrenaline doesn't increase the heart rate. That is where it may be useful during acute MI, where we don't want to increase the heart rate because it can worsen the ischemia. So this agent is used along with dobutamine or milrinone. And it has got minimal effect on the cardiac output. The dose usage is 0.2 to 1 microgram per kg per minute. Coming to the other vasoactive agent, that is vasopressor, is vasopressin. Vasopressin is a very potent vasopressor. It causes arterial smooth muscle cell contraction through a non-catecholamine receptor pathway, and it is an attractive adjuvant for improving organ perfusion in septic shock where catecholamines are ineffective. In severe sepsis and MODS, even noradrenaline will not be effective. In those circumstances, vasopressin is the only agent which increases the SVR, which improves the perfusion pressure and maintains the blood pressure. It is also useful in cardiac arrest as adjuvant to adrenaline. Of course, adrenaline is first line, and vasopressin is also used after using adrenaline for a few times. The dosage is 0.02 to 0.04 units per minute. This is not per kg, this is units. Okay. And higher doses can compromise tissue perfusion. There are a lot of side effects with vasopressin. So when we are using vasopressin, we have to be careful. We should not be happy with the blood pressure and going on increasing the vasopressin, because it is like you are closing all the taps and watching the level in your tank. So tissue perfusion will be adversely affected if you use high doses of vasopressin without correcting the volume and all. So having spoken about the inotropes, which is the best, there's nothing like a best inotrope. What we call it as horses for courses. So according to the patient condition, we have to use a particular inotrope or a combination of inotropes. So is there an ideal positive inotrope? What are the properties? It should enhance the contractility without increase in heart rate, afterload, and myocardial oxygen consumption. It should enhance the diastolic function, should have rapid titration times and onset of action and short half-life. We are still looking for ideal positive inotrope. Still research is going on. Among the available inotropes, as I said, it depends on the condition of the patient, and it is like horses for courses. As for my choices, I tend to use as first line dobutamine, sometimes alone or in combination for milder as a milder form of cardiogenic shock or a hypotension. Whereas second line inotrope is dobutamine along with adrenaline or noradrenaline based on the perfusion pressure. And when there is difficulty in coming off bypass during cardiac surgery, we tend to use adrenaline. If there is a RV dysfunction or if there is a high pulmonary artery pressure and if there is congestive heart failure, the drug of choice here is milrinone plus noradrenaline or levosimendan. If there are AV blocks or if there are mitral valve with high PAH or in congenital heart surgeries, we use isoprolol to improve the heart rate. If there is septic shock, agents of choice are vasopressors like noradrenaline and vasopressin. With this, I talk and thank you all for patiently listening, and thank you, Dr. Meenakshi Sundaram, for giving me this opportunity.
Thank you, Dr. P.S.N. Raju, for that excellent talk on use of inotropes. You dealt with the definition, the indications, and what are the available agents, how the inotropes act, and do we have a perfect inotrope? In this group, you have mentioned about the differentiation between vasopressors and inotropes, very important point. And also you have mentioned about the individual characteristics of each of the inotropes. Will you please stay back till the end so that we can take the questions?
Yes, sure.
Thank you so much. With that, we will go on to the third talk of the day, the final talk, Dr. Subhendhu Sarkar. I invite him to talk about the mechanical support in a phaneal heart. And we are looking forward to this talk. Subhendhu, as you all know, is a accomplished anesthesiologist from Calcutta. Dr. Subhendhu, please start your presentation.
Sir, is the slides visible?
Yeah, we can see it.
Okay, sir. So in coming 35 to 40 minutes maximum, the topic that has been allocated to me is the mechanical circulatory support. Before starting my presentation, I would like to express my gratitude to Dr. Meenakshi Sundaram sir for allowing me to participate in the webinar. Last year also I participated. And thank you, Murli sir, for introducing me. And the previous speaker, P.S.N. Raju sir, has very nicely, because I also learned a lot of things because it was presented in a very concise way. So now my duty is to make a journey through the mechanical circulatory support. See, the introduction, the heart failure is a complex clinical syndrome that characterized by the pulmonary and the systemic congestion due to myocardial dysfunction leading to the reduced cardiac output. And it is almost 1 to 2% of the adult population and approximately 1 million new cases per year. While the heart failure outcomes has improved with the use of the application of the evidence-based therapies that we have already learned in the last presentation, the death rate remains high, approximately 50% within the 5 years of diagnosis. The heart failure is a progressive disease with approximately 10% of the overall heart failure population having the end-stage disease with ongoing symptoms refractory to the conventional therapy. This is actually the beginning of my presentation, and over the last 50 years, cardiac transplantation has been established as the gold standard. However, the cardiac transplantation limited option for a selective number of the patients, because there are a lot of the things that we need to consider before a patient is getting or the patient is selected for a cardiac transplantation. So just once, I don't know what's happening. It's not moving. Yeah. So the need for the transplantation outpaces the availability of the donor organs, and accordingly, the mechanical circulatory support device in the form of the durable left ventricular assist device specifically is a central therapeutic alternative to improve the quality of the life and the longevity of the patient who are either waitlisted or ineligible for the heart transplantation. This is actually the way the mechanical circulatory support has introduced. It's potentially capable of permanent mechanical support, and first implantation of the LVAD as a bridge to the transplant therapy is performed in the year 1984. So now the introduction is over. Now the next question comes, what are MCS devices? The mechanical pumps that designed to assist or replace the function of either the right heart or the left heart or the both ventricle. And the MCS devices are indicated to provide the hemodynamic support to the patient with cardiogenic shock or symptomatic advanced heart failure that are refractory to the guideline directed medical care. It decreases the workload of the heart while maintaining the adequate flow and the blood pressure. This is what we understand about a mechanical circulatory device. If we start our journey from in the year 1950 with the roller pumps with cardiopulmonary bypass, it ultimately, with the evolution of the roller pump to the pulsatile to the centrifugal, then come to the axial flow, now to the magnet technology in 2020. We'll make a small tour of this because I know there are lots of postgraduate students are there. Probably this is not actually important for your postgraduate examination, but obviously those portions what I personally feel is important, I'll give a bit more stress on that. So now the next thing we need to know, that is the Intermax profile. What is Intermax? Intermax is the interagency registry for mechanically assisted circulatory support. If you see the profiles, Intermax 1 to Intermax 7. Intermax 1 is when the patient is in critical cardiogenic shock and detailing the life-threatening hypotension in spite of the rapidly escalating inotropic support. You are escalating the inotropic support, you are making a combination of that, but it's not actually improving. And Intermax 2 a bit more stable, and if you come to the Intermax 7, it is actually the advanced NOIHA class 3, that is the patients living comfortably but with meaningful activity that limited and mild physical exertion. And now if we reciprocate this Intermax profile, you can easily understand for Intermax profile, if you follow my cursor, it's 7. That is when the patient is having an heart failure, but patient can live a good life and other. It's actually the months to years in the survival. The ventricular assist devices, that is the mechanical circulatory supports, has not been well established. 3 to 4 weeks to months is established. 1 to 2 hours to weeks is established, and multi-organ failure, it breached to the decision in a selected cases. So this is actually how, with the intermax level, the presence of the mechanical circulatory support stays right now. Now we need to know something about the common terminologies. Number one is the bridge to recovery, that is a potential reversible cause. Then the bridge to bridge, that is we giving a temporary mechanical circulatory support. It continued as a bridge for a long-term mechanical support in the form of LVAD. We have a bridge to transplant. We have a destination therapy. That's a recovery of the transplant is not feasible on those type of individuals. Next, the bridge to candidacy, when the eligibility unclear at implant or with the comorbidities. And the bridge to decision, the potential for the transplant or recovery is unclear. So these are the in general terminologies used with the mechanical circulatory support. Now, the guideline for the initiation of the mechanical circulatory support. In general, if you follow my cursor, generally accepted guidelines, in spite of the optimized medical management, the cardiac index is less than 1.2 to 2.2, systolic blood pressure is less than 90, wedge pressure is more than 20, RF pressure is 18 to 20 millimeter of mercury, and evidence of the poor tissue perfusion in the form of oliguria, mental status change, cool extremities. And general, the for the MICS, irreversible renal, hepatic, or the respiratory failure, sepsis, and the significant cognitive deficiency, we usually take it as a contraindication list for the mechanical circulatory support. Now, indications of the ventricular assist device, which is a form of the mechanical circulatory support. The number one is the chronic heart failure, where the ejection fraction is less than 25%, VO2 is less than 14, NOIHA classification 4 for 60 days, and NOIHA classification 3 or the 4 for 28 days. And simultaneously, the patient is having IABP support for 14 days or 2 failed attempts to win the IV inotropic support. Next, the increasing diuretic requirement and symptomatic in spite of the CRT or the inotropic dependence. So these are the under the heading of the chronic heart failure, the indications of the ventricular assist device. Number two, acute refractory cardiogenic shock, a fulminant myocarditis, AMI with cardiogenic shock, a peripartum or the Takotsubo, and the post-cardiac surgery. We are not being able to take the patient off from the cardiopulmonary bypass and the unable to maintain the cardiac output. Number three is a bridge to recovery, where therapeutic strategy is small subset. So these are the all three major headings of the indications of the ventricular assist device. For a durable mechanical support, we are having almost the same indications and contraindications. I'm not going to details the how the mechanical circulatory support is being placed. This is a publication that is being taken in 2022 AHA, that is a class of recommendations, and simultaneously the 1, 2A and 2B, we are placing the mechanical circulatory support where in our indications level. Now, what are the contraindications for the ventricular assist device therapy? One is an active systemic infection, high surgical risk for the successful implantation, a recent or the evolving stroke or the neurological deficit, fixed pulmonary and the portal hypertension, intolerance to the anticoagulation, morbid obesity, CKD with serum creatinine level more than 3, restrictive cardiomyopathy, and significant underlying psychiatric illness or the lack of support. These are usually taken as a list of contraindication for ventricular assist device therapy. Now, coming to the classification of the ventricular assist device. So, depending upon the mechanism, durations, and the placements, we can divide in 4 broad headings. One is based on the pumping mechanism. If it is a pulsatile or a continuous flow in the form of axial, centrifugal, or the mixed. Number 2, it's based on the location of the pump chamber. It can be an intracorporeal or it can be an extracorporeal. Now, number 3, based on the ventricle supported. It can be a left ventricle for the LVAD, right ventricle for the RVAD, and both ventricle for the BiVAD. Based on the duration of the support. If it is a short term, days to weeks, or a long term, months to years. Now, for a ventricular assist device placement, what are the things to be start with? The pre-op assessment usually start with a coronary angiogram, we need to evaluate the details of the RV function in the form of using an echo and simultaneously the right heart catheterization. Both are extremely effective to give you a real-time scenario, what is happening and what are the scope of pharmacological management to make or prepare that particular patient for getting this ventricular assist device to be implanted. These are in general the components of the ventricular assist device. Usually we have an outflow, we have an inflow, and this is a pump. So components is an electromechanical pump. We have an inflow cannula. It decompresses the ventricular cavity. For an LVAD, it originates from either left atrium or from the right ventricle. For an RVAD, it originates from the RA to the RA or RV. For a BiVAD, it originates in both atrium or both ventricle. So this is the inflow cannula component for a ventricular assist device. Now the pump. Number 3 pump, it provides the propulsion of the blood. Flow can be a pulsatile, it's pneumatically or electromechanically driven, or non-pulsatile, it can be an axial, centrifugal, and the mixed. Now the pump can be implanted subdiaphragmatically to the preperitoneal, intra-abdominal, or the paracorporeal position. Outflow cannula, it can be we have an inflow cannula. Now the outflow cannula can be either in an ascending aorta for a LVAD and main pulmonary artery for an RVAD. Now the controller operates pump by receiving and processing the information and then the percutaneous drive line. So these are the 7 components for any ventricular assist device. This is a schematic diagram. This is our first LVAD implantation. You can see this is actually when the training was going on. This is the outflow cannula. This is the inflow cannula. This is the pump, and this is a that goes directly to the electromechanical device. This is the picture of our right heart catheterization, how we are optimizing the patient before declaring that patient is actually suitable from the right heart catheterization point of view. That patient can undergo the LVAD implantation. This is a small video. I won't be able to show you in detail. You can see this is how this is our first LVAD implantation. You can see. So you can see this is the cannula that is placed in the left ventricle. Okay. Coming to the next video. You can see this is we are connecting. I can spend few seconds here how it has been done. It's fully primed. You can see there is no air and other. Yes, now the perfusionist is asked to fill the heart. So from the inflow cannula it is coming. And now it's attached. Okay. Okay. You can see the attachment has been done. Okay. Okay. Coming to the next one. You can see this is the pump placed in the preperitoneal position. And now the tubes has been taken out from this. I'm just forwarding the videos because we don't have much time. You can see it has been coming out. Yes. So you can easily understand that. Okay. Now here we are going to show you the outflow cannula. You can see the outflow cannula is been connected to the aorta as because it is an LVAD from the left ventricle to the outflow cannula. Yes. Okay. Now you can see the placement of the LVAD. It has been placed and the pocket electromechanical pump and simultaneously is connected to the aorta. Right. Okay. So this is I just took showed you some of the videos to make it clear. It actually in the real situations how it looks like. So the physiology of the LVAD, in the centrifugal phases, what is the difference between an axial and the centrifugal pumps. So in general, than in axial, it's steep and the inverse linear, the relationship between flow and pressure, which is flatter and the more susceptible, depend on the preload. In centrifugal, both preload and afterload is extreme. The flow range is 3 to 7 liters and 0 to 10 liters flow for a centrifugal pump. So hemodynamic characteristics of a centrifugal pump that translate into the more pulsatile waveform, more accurate flow estimation, low risk of the suction, and more dependency of the device flow and the loading condition. So the third portion of my presentation is the type of the mechanical circulatory support. In general, the first one to start with the short-term mechanical circulatory support. It is a temporary mechanical circulatory support is indicated in patients with cardiogenic shock refractory to the medical therapy when rapidly achieved augmentation of the cardiac output and reduction of the ventricular filling pressures are required to sustain the life. In general, these are the four component. These are the four mechanical circulatory support devices that is actually for the short-term use. The number one is the intra-aortic balloon pump. We spend few slides for intra-aortic balloon pump. I think even the postgraduate student should know at least the basic of this. Next is an ECMO. We don't have, it is absolutely a separate chapter and separate class another. Next is an impeller where LV to the aorta assist device, and the next one is a tandem heart where it is left atrial to the aorta assist device. So these are the four important mechanical circulatory support device of short-term use. Now, a few words will spend at least 5-7 minutes time for an intra-aortic balloon pump. The intra-aortic balloon pump remains the most commonly used MCS devices. The IBP consists of a balloon and a pump console to control the timing of the balloon inflation and deflation. I'll request my all postgraduate friends, just listen it very carefully. It is important and you need to understand. The catheter is a double lumen 7.5 to 8 French catheter with a polythene balloon, and it is the helium is used because it is low viscosity, it facilitates rapid transfer in and out of the balloon, and because it absorbs very rapidly in blood if the balloon ruptured accidentally. In IABP, the timing of balloon inflation and deflation is based on the ECG or a pressure trigger. We have both the facilities, and the balloon inflates with the onset of diastole, which roughly corresponds with the electrophysiologic repolarization or the middle of the T wave on the surface ECG or just after the dicrotic notch of aortic pressure tracing. So you can find out both with the inflation that occur actually in diastole with the dicrotic notch or the middle of the T wave. Either it can be a pressure trigger or an ECG trigger. And next, following the diastole, the balloon rapidly deflates at the onset of the LV systole, which is timed electrocardiographically to the peak of the R wave on the surface ECG. The IBP increases the diastolic blood pressure, that decreases the afterload, it decreases the myocardial oxygen consumption, and it increases the coronary artery perfusion, and modestly, it ultimately enhances the cardiac output. In nutshell, these three lines actually describes the entire how the IBP actually helps. This is the different size of the balloon starting from the 25, 30, 35, 40 and the 50 cc. These are, you can see the console with the monitor with I'll show you the card later on in the slide. And the mechanism, understand very carefully, the inflation at the aortic valve closure, that is in diastole. So it increases the aortic diastolic pressure, it increases the diastolic coronary perfusion, the net neutral effect on cerebral perfusion, and increases cardiac output or the runoff to the subdiaphragmatic organs. The deflation exactly occurred prior to the systole, and it reduces the impedance to the LV ejection and reduces the myocardial oxygen consumption. So these are the two main things, that is by increasing the diastolic coronary perfusion and reducing the impedance to the LV ejection by reducing the afterload. These are the two actual mechanisms of intra-aortic balloon pump. This is a small video for you that is just to show you the different components of the machine, and simultaneously when the balloon is inside the aorta, it how actually inflates and deflates. Probably you will like it, this video. I'm making a bit skip. This is the machine. This is the helium cylinder you can identify. We also having a Doppler machine to find out if there is any limb blockage and other, and we need to evaluate every day. We need to evaluate every day because once the patient is in intra-aortic balloon pump, you need to evaluate the dorsalis pedis artery pulsations and other everything, whether the patient is having limb ischemia or the pulse has come down or other. You need to check it before and even after the IBP insertion. So these are you can identify. This is how the ECG trigger, pressure trigger, and this is the frequency. This is the augmentation level. This is the IBP inflation and deflation. We need to adjust accordingly. This is the augmentation level. This is the Doppler machine. We usually check the limbs nicely prior to the insertion of the balloon. The transducer has been set. This is the balloon. Now I am inflating the helium gas into it. We are making the helium cylinder on. And now we put the start button. Now you see, you look carefully to the balloon. The helium gas is inflated. Now you can see the inflation and deflation. It actually happens inside the body. Okay. So you can easily identify now the unassisted systole and diastolic augmentation with an assisted systole by identifying the notch and the ECG. So now the question comes, what are the indications of IBP? Cardiogenic shock complicating AMI prior to the high risk of the percutaneous coronary intervention. Prior to the high risk CABG, electively we put severe acute myocardial mitral regurgitation, ventricular septal rupture, rescue after failed PTCA, going for the CABG, and breach to the ventricular assist device in patients awaiting transplant. So these are the indications of the intra-aortic balloon pump. Severe aortic insufficiency, aortic aneurysm, aortic dissection, limb ischemia, and thromboembolisms are the contraindications of intra-aortic balloon pump. When you will start weaning the IBP, normal arterial pressure, cardiac index is more than 2.2, your pulmonary capillary wedge pressure is less than 80, frequency ratio is 1:1 to 1:2 to 1:4. This 1:4 is actually the frequency ratio when you start weaning, and volume reduction to 20 to 25%. These are the some supportive articles. That is a class 1C recommendation that is actually in 2005 Journal of Thrombosis and Thrombolysis. They have compared with an post PTCA patients. They are finding out the 6 months mortality. One group with only fibrinolysis, another group fibrinolysis with an IBP. This is another in 2010, that is a shock trial, very important trial, where they identify the Apache score and the inflammatory markers, and in the reform of the result of the BNP, and they find out when an IBP therapy it come down. And it is in 2012, the intra-aortic balloon pump for the myocardial infarction with cardiogenic shock, they identify the endpoints with a 30-day mortality. There is a 39.7 in the IBP group versus the 41.3 in an optical medical therapy group. Now, one thing is, after the IBP, this is only single slide I have kept, that is an intravascular ventricular assist system. This IVAS is an external heart assist device. It is a fully ambulatory counter pulsation device intended for more prolonged hemodynamic support in an outpatient setting, and potentially it is less advanced in heart failure, less advanced heart failure patient. In a severe heart failure, we cannot use IVAS. This is how the IVAS looks like. Now I have to go a bit fast because it's almost 25 minutes over. Extracorporeal membrane oxygenation ECMO, we all know how the ECMO works with the venovenous and the veno-arterial ECMO, and this is how this ECMO works. So in general, this may have the negative consequence on the myocardial recovery unless, so what actually happened because of the, so ECMO can be configured for a respiratory support with the venovenous and for the circulatory support in the form of the veno-arterial. In case of the biventricular failure, VA ECMO and the mechanical circulatory device is the mechanical MCS device of the choice for the patients in cardiogenic shock and impaired oxygenation because it provides full cardiopulmonary support. The few things you need to know, that is because of the increased systemic afterload. However, the VO ECMO alone may not be significantly reduce the ventricular wall stress and may result in an LV distension in cases where the residual LV function is inadequate to eject against the increase in the systemic afterload. And this may result in a high myocardial oxygen demand. So this may have the negative consequence on myocardial recovery until the left ventricle is unloaded by a concomitant IABP support or a left ventricular vent or an atrial septostomy in intraatrial septum or use of a percutaneous LV to aorta ventricular assist device. So these are the things you need to understand. Just only giving ECMO, it may not, because the situation can be something like that. The LV is getting over distended because of the systemic afterload increase and it may not recover properly. So the most important thing is, apart from giving a support, the most important whether your ventricle is getting properly unloaded or not. That is the most important. This is the VA-VV ECMO. So we are not discussing anything ECMO. The next one is a left ventricle to the aorta assist device, which is called Impella. Impella is a continuous flow microaxial pump designed to pump blood from the left ventricle to the ascending aorta. Then to the heart. You can see this is how the pump is placed. Okay, so this is in short how the Impella. Now the left atrium to the aorta assist device, which is called tandem heart. So this is the tandem heart. This is how the tandem heart looks like. I'm just only show you the animations and other. No need to read so many things because the time will not. You can see the septostomy has been done from the RA to the LA. The tube has been given. This is the tandem heart cardiac assist device, mechanical circulatory support. This is how the pump looks like. And it will drives. Okay. So the types of the ventricular assist device already now in another form, the first generation of having the pulsatile flow pump, second generation having the continuous of the axial flow, and the third generation is a centrifugal of the continuous flow pump. This is the difference between the first versus second or the third generation. You can easily identify the size of the LVAD with the second generation and the third generation is smaller. Durability is more durable. Having the preload and the afterload output determines both, not only preload like first generation. The position of the pump can be intracardiac, intrathoracic, and the apex. So you don't need to put in an abdominal or the pre-peritoneal position. Pump activity up to 10 liters per minute. The moving parts is only motor. It's thin and flexible and long duration. And obviously, it has less thrombogenicity in comparison to the first generation device. This is the all more or less variety how the first generation pump to the third generations having. So we are not going into this. The first generation of the pulsatile flow pump is the HeartMate 1, HeartMate XV, and the Novacor VAD. This is the HeartMate 1. This is the HeartMate XV Thoratec, and this is the Novacor VAD. And the second generation having the HeartMate 2. The HeartMate 2 actually the video what I have shown you in the first one. There's the Thoratec, the Javik 2000 Berlin, and the Micromed Diveki. This is the HeartMate 2 Javik and the Berlin Heart Encore, and this is the Micromed VAD. And the third generations I already mentioned, the ventricular assist device as the Ventracort and the DuraHeart. This is the external and the internal view of the third generation of the continuous flow rotatory left ventricular assist device. You can see everything is placed in the heart apex. No need to put it anywhere. So these are the beauty of the third generation mechanical circulatory support device. This is a total artificial heart. You can see total artificial heart. Here the human heart dying from the end-stage biventricular failure. the complete support of severe biventricular failure. In situation, you can simultaneously go on seeing the animations also. In situation where the living native heart is placed detrimental, cardiac tumor, aortic insufficiency with prosthesis, arrhythmia, LV thrombus, acquired VSD, and currently approved for the biventricular support at bridge to the transplant therapy and humanitarian use device designation for DT. So you can see when a donor heart becomes available, the SynCardia total artificial heart and quick connects and remove. The donor heart is get transplanted. So this is how the total artificial heart is being used. So the last portion is the complications of the ventricular assist device, the bleeding risk, thrombosis, hemolysis, infection, and the depression and the adjustment disorder. This is one of the extremely important. We usually give more focus on this point 1, 2, 3, and 4. We usually ignore the point 5. Believe me, this point 5 is an extremely important issue whenever you are putting one devices, just like devices like mechanical circulatory device inside your thoracic cavity. The depression and the adjustment disorder with all these consoles and everything, this is one of the most important. You need a strong counseling of the patient. The complications is cardiac related, is an RV dysfunction. The aortic valve is actually closed. So the blood status and cause formation chance is there. Aortic insufficiency and ventricular arrhythmia. The LVAD related, the pump thrombosis, device failure, increased afterload and the shutdown. And the post-op surveillance is clinical assessment, echo, right heart catheterization, and adjustment of the vasodilator, diuretics, and the pump parameters. So to summarize, the algorithm of the device therapy is we need to identify the ventricular assist device candidate first. Next, the anticipated duration of the support, for how long we want to place it. Then the device indications, what are the indications, and simultaneously common use devices options what we have. I have more or less showed you all the options currently available till now from the start. So refractory heart failure, we need to go for a short term or a long term. For a short term, either it a bridge to decision or bridge to recovery. The best one is an Abiomed or the tandem heart or the Centrimac. And for a long term, end stage congestive heart failure, that is a bridge to the transplant or the destination therapy. For a destination therapy, we have this thoracic HeartMate, or for a bridge to transplant, HeartMate 2 or the Micromed DBK or the Javik. So to conclude, it is a future of end-stage heart failure, improving the quality of the life, improving survival, and it either acts as a BTR, BTT, or as a final destination. So thank you for patient listening. But before we sign up, I'll take another 30-40 seconds from you. As you know that the new chapter, that is the Indian Society of Intensive Care and Perioperative Medicine West Bengal State Branch, has already been inaugurated in the month of March. Our process and other things is complete. The West Bengal government registrations and everything has been done. And under the banner of Indian Society of Intensive Care and Perioperative Medicine West Bengal, we are going to organize the second national conference in Calcutta. The date of the conference is 31st of October and 1st of November 2025. That is a Friday and Saturday. And 2nd November 2025 is a Sunday workshop. This is the second national conference of Indian Society of Intensive Care and Perioperative Medicine. This is our website, myself, the organizing secretary, and our venue is Hotel Hindustan International, Kolkata. I'll send the invitation and request to you all, and obviously I'll be happy, our entire team will be happy if we get an August gathering like you in Calcutta for these 3 days. So save the dates, please, for 31st October, 1st and 2nd November. Thank you very much.
Thank you, Subhendhu, for that excellent description of the use of mechanical circulatory devices in patients who suffer from heart failure. You covered the topic in a very concise manner. You touched all the aspects. You started with Intermac's classification of heart failure. What are the guidelines? The indications, classification, components, and the hemodynamic characteristics. Types of mechanical circulatory support, basically you mentioned 4 major types. the IABP, ECMO, Impella, and tandem heart. And also you mentioned about the, most importantly, you mentioned about the importance of unloading the left ventricle in ECMO, very important point. And you finished with complications and other things associated with the left ventricular devices. Thank you. And the topic is open for discussion. If you can unshare the screen and put on your videos, we'll go through the chat box questions and any other question which anybody might like to ask.
Dr. Subhendhu, you please stop sharing your screen.
Okay.
Please
Hello.
yeah.
Hello. Yeah, this is Dr. Ambesh here from Lucknow.
Yes. Please.
Yes. I got superannuated last year as professor and head of anesthesiology and intensive care from SGPGI and dean of SGPGI.
Right.
At the moment, I am working as a director critical care at Paras Hospital.
Super.
So I have few comments and one request to make.
Yes.
So with the permission of the chair, Dr.
Yes,
Kanchi, actually, this era is the era of, you can say, the evidence-based medicine. Okay.
Yes.
So when we are treating a patient of cardiac failure, we have to be on the basis of some evidences. I mean, what we want and what is wrong with the heart. Okay. So first of all, before going on the comment, I must compliment and congratulate all three speakers because they have done justice with their respective topics and they have covered it very well. I feel that instead of inotropic drugs, it should have been like a cardiotropic drugs because inotropes is a one set of cardiotropic drugs. So cardiotropic drugs covers inotropes, chronotropes, dromotropes, lucitropes, bathmotropes, all those set of drugs. They are the cardiotropic drugs. Inotropes covers only the inotropic effect. Okay, so better to design, or you can say the nomenclature is cardiotropic drugs. Second thing is, before you select any cardiotropic drug in a case of heart failure, you have to see whether the patient is having systolic heart failure or diastolic heart failure, or it's a vasoplasic heart failure. Vasoplasic means heart failure means that the systolic function is okay, the diastolic function is okay, but the patient is having severe vasodilatation. It's a vasoplegia only. Okay, and that can occur in case of septic shock or other drugs toxicity like vasodilation, severe vasodilation suddenly. So we have to do the echocardiography and see what is wrong. Okay, so how the things are behaving. And second thing is we have to see not only all these inotropic and chronotropic or lucitropic effect. We have to see the what is the oxygen flux. We have to see the respiratory function also, because the heart must get good amount of oxygen and nutrients so that it can eject good amount of oxygen, because that is required for good cardiac function. Secondly, we have to start, you have to have a good euvolemia. We have to have normal electrolyte balance or within the range. We have to not only the sodium, potassium, but we have to see what is the level of calcium, what is the level of magnesium as well. So all four electrolytes have to be within the normal limit, and we have to correct, okay, over a period of time. So that is important. So we have to see what is the oxygen flux. I mean the oxygen amount, the hemoglobin, the ejection, and everything. Thirdly, what is the coronary perfusion pressure? We have to calculate the coronary perfusion pressure also. Otherwise, patient will develop global ischemia. Okay, so the coronary, if the diastolic blood pressure is, say, for example, 30, I have seen number of patients where the systolic blood pressure is 120, 110, and diastolic blood pressure is around 25 or 30. So in this case, the patient will have very low coronary perfusion pressure. And when there is a low coronary perfusion pressure, the patient will develop global ischemia. Okay, so we have to correct that thing also, and seeing what the patient needs, whether it's volume and the inotropic support or chronotropic support. And we have to select the drug according to the all five I said: inotropic, chronotropic, dromotropic, lucitropic, bathmotropic effect. So, and then we can have the mix or combination of number of drugs. So that is how one should select. So this is the basically regarding my comments and request is, I'm the founder, president of the Indian Society of Intensive Care and Perioperative Medicine.
Oh,
We last year we successfully organized our first national conference, and this time Dr. Sarkar, Subhendhu Sarkar, is organizing the second national conference of Indian Society of Intensive Care and Perioperative Medicine. I have two requests to make. One request is, first, all honorable members are requested to become the member of this society and form your state branch, like the Tamil Nadu state branch and Karnataka state branch, or whatever state you belong. So state branch, if you can make, then it will be a better thing. And thirdly, you all are requested to become a faculty and be the part of this second national conference. Thank you very much.
thank you very much for your input. Some of the valid points you have raised, that's very, very appreciable. Regarding I am coming from the last point you made, the Indian Society of Intensive Care and Perioperative Medicine. I am very happy to know that you have created another platform where we could meet and discuss patient-related matters in terms of intensive care and anesthesia. Certainly, we'll become members, and we will also see how we can open the state branches. Absolutely no problem. Thank you for that information, and we will take this thought process forward, and we will see that this society will reach the prominent place which is due to be due as much as any other society, or even better. Thank you so much for that. Coming to the points raised by you regarding the cardiotropic drugs, the topic given to us was inotropes. That's why we discussed about inotropes. But if the organizers or the scheduling persons who made this seminar had they made cardiotropic, absolutely we would have covered other agents. And I would like to listen to Dr. P.S.N. Raju on this matter. Usually we put it as vasoactive agents, so which covers everything A to Z, starting from inotropes to vasodilators, vasopressors, etc. But cardiotropic drugs, if you want to make it, certainly we can make. It depends upon the topic, what is given to us. So based on that, we have discussed. Dr. Raju, do you want to say anything on this matter?
Yeah, I agree with what you said, sir. The topic given to us was inotropic support. I think this is basically meant for the postgraduates. To avoid confusion, I didn't bring in too many terminologies.
Right.
Even though in the beginning of my talk, I have distinguished between a chronotrope, inotrope, and a vasopressor. And the confusion, what should be avoided between a vasopressor and inotrope, because their mode of action and their effects are different. That is one.
I agree with you. So at the inotropes, there's a lot of confusion, what to use, when to use, how much to use, all those things. So I think the organizers wanted to cover that bit, and I do appreciate that the organizer wanted to talk about inotropes, and that's what we have done.
Sir,
This
moderator, sir.
yeah.
Sir, moderator, sir, with your permission, as we have given the topic, see, our idea is to reach the youngsters. See,
Right.
you have your experience of anesthetizing more than 20,000 cases cannot be pressed into the minds of young individuals. There will be a ventilation perfusion mismatch. If it is so, there will be definitely a ventilation perfusion mismatch. See, we want to go down to their levels till they become the stalwarts in cardiac anesthesiology. We don't want any confusion. Even we will request the faculty not to post any research paper details, because the youngsters will be confused. We want to give them the clear-cut take-home points. That is the reason why we specifically stick to one agenda. And even now, the question, there are so many chat box questions, sir. Even one of the question is, what is the difference between ionotropism and leucotropism? What ionotropic is
That
the
we're
choice
coming
of
to
best?
that.
Yeah, because they are asking, even they are asking, so we will address them. because within 1.5 hours, now we are already exceeded time. Within 1.5 hours, it is very difficult to cover the entire expertise of the faculty. That is the right.
That is true.
Dr. Sundaram,
Sir?
sorry to interrupt. Dr. Sundaram, the point is well taken. The thing is, there is no drug which is a pure inotrope, because most of the drug have either inotrope plus chronotropic action, or inotropic plus bromotropic action, or inotropic plus lucitropic action, or bathmotropic action. So there is no drug which
We will
contains
ask
only
Dr. P.S.N. Raju about his opinion.
Sir,
No,
this
we
is
ask
at
problem.
your level, but we are asking only university questions, sir. We have set up the topic, only university questions will be the topic of choice, so that there is no this is an average physician's role, not like experts like you, sir.
We asked,
Because for example,
one second,
noradrenaline.
doctor. Please give us also a chance to talk.
Okay,
We
sir.
will
Okay.
ask Dr. P.S.N. Raju. If there is any pure inotrope, let's ask the experts. So, Dr. P.S.N. Raju, do you think there is a pure inotrope? My colleague says that there is no pure inotrope.
See, that's what each agent has got a slightly different type of effect. Like milrinone is there, it has got inotropic action, but most of these inotropes also have got chronotropic action in the doses.
It has a
Depends on
lucitropic action
the
also.
dose also.
You have put forward all the points. We'll go through one of them quickly because Meenakshi already indicated that we are short of time.
Thank you.
So when it comes to the drugs, most of these drugs have dose-dependent action. Please note, dose-dependent. Smaller the dose, the action is different. Medium dose action is different, and higher dose action is different. To answer your point, that is there a pure inotrope? Dobutamine is the closest agent which comes very near to what is called as inotrope, because it has beta-1 effects which increase the cardiac contractility. It also has beta-2 and alpha actions which cancel each other. So ultimately you got almost a pure myocardial contractile increase with dobutamine. So though it is not a perfect inotrope, it is somewhat close to a pure inotrope. That's my response. Now we'll go to the next comment you made about the oxygen flux and respiratory function. P.S.N. Raju, do you want to answer that one?
No, I think, yeah, that is going too much into the topic. I wanted to make it as simple.
Oxygen flux. No, oxygen flux. I mean, more than oxygen flux, is the oxygen content of the arterial blood which is reaching the tissues.
Yes, you are right.
Oxygen content, which is hemoglobin and the percentage of oxygen saturation plus the dissolved oxygen, how much is going, and what is the position of the oxygen dissociation curve is important. Even if content is good, if the oxygen dissociation curve is to the left, it will not be delivered to the tissues. So these two factors are important. The third point you mentioned about the euvolemia, absolutely correct point. Especially when you're using drugs like levosimendan and milrinone, if they are not euvolemic at that point of time, they will develop hypotension and the purpose is defeated. The fourth point about coronary perfusion pressure, absolutely correct point. The difference between the aortic diastolic pressure and the LVEDP is important for coronary perfusion, and it should be taken into account, especially in patients who have ischemic heart disease. Now we'll go on to chat box questions quickly. Are there any oral inotropic agents?
I think digoxin is the oral inotropic agent of means time tested. It has.
Yeah, I agree with that. And there was one question on lucitropism. What is lucitropism and which drugs have lucitropism?
Lucitropism is nothing but the relaxation of the ventricle.
Yes. Lucitropism is the rate of myocardial relaxation, and the drugs like milrinone, dobutamine, and to stomach vitamin have lucitropic, and it can be used in patients who have diastolic heart failure. There is something about bupivacaine. I think I'll skip that question. That's not
That
relevant.
is not related to this, sir.
That I'll skip. And
Answered. Dr. Jayati Ghosh has asked, can we access the seminar afterwards? This is for us. Yes, we will send the YouTube link within 3 days. You will get the YouTube link. Questions are answered.
Yes, Subhendhu. Yeah.
we have 1 more minute.
Subhendhu wanted.
Doctor from Lucknow, if you want to say anything, there's 1 more minute. You can.
Subhendhu Sarkar is over. Sir, tell me. Sir.
Subhendhu, yes. Yeah.
Yeah, sir, actually, after Corona in West Bengal, the levosimendan is not available. But before that, I used this drug like anything. Sir, particularly in a bad ventricle patient, the diastolic dimension is more than 5.5 and having a component of grade 1 or 2 mitral regurgitation, where surgeon is also a bit confused whether they will touch the mitral valve or not. This drug works fantastic for an off pump. But the most important thing, sir, until and unless we put some advanced hemodynamic monitoring for these particular individuals, we may end up to the drastic hypotension that we need to counteract by giving different drugs, particularly continuous monitoring of a cardiac output and the systemic vascular resistance. I think these are the 2 parameters we have to monitor continuously for a drug like levosimendan. It's a fantastic drug, but hypotension occurs very suddenly. Very suddenly, we find out that there is a diastolic hypotension.
Totally agree with you. The advantage with levosimendan and milrinone is that they bypass the beta adrenergic receptors.
Exactly, sir.
And they can be used in patients who are in heart failure where there is a down regulation of the beta receptors, which this was pointed out by P.S.N. Raju very correctly.
Murli sir, is it available there in Bangalore? It's available. Levosimendan is available.
It is available. Yeah. Semenda is the trade name. It is available.
Yes, that was actually available. But in West Bengal, after Corona, we are simply no companies. Even the Neon has started marketing this in pre-Corona level. But in West Bengal, levosimendan is not available. That's why I'm asking.
I used it about 2-3 months back.
Sir, one more question for you.
Yes, sir.
When a patient is receiving multiple inotrops, how do we go about tapering them? Is there any algorithm?
A very good question, actually. Not only tapering, actually, we as cardiac anesthetists, even when we are starting inotropes, mostly we have good invasive monitoring, including the cardiac output monitoring, SVR monitoring. So the ideal thing, like Dr. Ambesh has mentioned, we should have an evidence-based protocol to start. So we have particular protocols to start any of these inotropes or their combinations. So invariably, I am a user of extensive user of pulmonary artery catheter. We use pulmonary artery catheter. We use radial artery based cardiac outputs like the flow track. We also use transesophageal echocardiography, for which Dr. Master is Dr. K. Muralidha. So we do use these modalities, and then only we use the inotropes, and we titrate them, we monitor them as per the hemodynamic parameters like SVR, PVR, cardiac output, stroke volume. We get extensive information. Today, the information from these catheters and these monitors is extensive. We have to use appropriately in a particular patient to start a particular combination of inotropes and see how they are acting, how each parameter. Suppose I start milrinone and suddenly my SVR drops. I am going to start some noradrenaline to increase the SVR, to bring it to a level. Same way, these parameters are very, very important for titrating the inotropes. That question is very good question. I don't blindly titrate my inotropes. I look at my parameters. How is the arterial pressure? How is the PA pressure? How is my SVR? How is my PVR? Based on that, I tend to come down on the inotropes. And as far as possible, if I am on high dose of vasoconstrictors, my first criteria, I always want to bring down my vasoconstrictor, like noradrenal or vasopressin. If I have started, I would rather come down on vasopressors, which are a hindrance to tissue perfusion. Absolutely. I rather continue my inotropes like milrinone or dobutamine for longer time because they improve the cardiac output, they make the heart to work well, and they reduce the afterload. So the heart muscle is relaxing and then it is pumping. So I want to reduce as much possible my vasoconstrictors, reduce my afterload. Like I'm going to my first point in the lecture, when I look at these parameters, I look at both heart rate, rhythm, preload, afterload, and also the contractility. I don't blindly go by one parameter. Like Dr. Ambesh has mentioned, volume is also important. If you start a vasodilator, like inodilator, like milrinone, without a proper volume filling, you will have adverse effect of that particular drug. You will be forced to withdraw that drug. So we should look at all 5 parameters: rate, rhythm, preload, afterload, and the contractility. Then only we should choose the appropriate agent. Like I said, horses for courses. In the same patient, during his hemodynamic course, the parameters may alter. When we start, the SVR will be very low. Then after some time, SVR goes very high. Then we have to take out the vasopressor. And sometimes, even in septic shock, we may start with a vasopressor, but you will see a myocardial dysfunction. You may have to put in subdobutamine to control that. So it is all continuous monitoring, and then based on the parameters, it has to be subjective. It is not like I use only adrenaline. I don't like vasopressin. These are not the things. We have to go by science. We have to use appropriate agent at the appropriate time, at the appropriate dose. I think that is more important. Just because we started 10 dobutamine, we should not continue if there is a tachycardia. Then we may have to. Or sometimes there is a tolerance to these agents. Tolerance will develop. So we have to use alternate agent. Suppose dobutamine, adrenaline not working, that patient, milrinone may be effective because beta-adrenergic down regulation is there. So this is all.
Sir,
Correctly replied. I think
short of time.
we want to wind up, is it?
Yes, sir.
Thank you so
We
much.
should not exceed
Final remarks by Dr. Muralidha.
That is a concluding remarks. So that is winding up. That is winding up.
No, I enjoyed thoroughly the session. Both all the 3 speakers have done. Only one passing remark I would like to make is that cardiac index was mentioned as 3.1 to 3.3 liters per minute per meter square. It is 2.8 to 4.2 liters per minute per meter square.
Okay, sir.
Otherwise, all the other sections are completely well done, and especially Dr. P.S.N. Raju and Subhendhu have touched upon the most important parts of the subject. And I would like to thank also the Ambesh for his input. Was some of the points were very valid, and we have made a note of that. Thank you so much. And we'll also join the organization which was mentioned, that the Indian Society of Critical Care and Perioperative Medicine. That's a good concept. Thank you so much. And I would like to thank Meenakshi and others in the Puthukkottai ISA branch for this excellent opportunity. And we would look forward to having more such events. And we would like to learn from you and have more discussion on the subjects which you might want to discuss. Thank you so much and good night.
Thank you, sir. Thank you, sir.
Thank you.
Actually, see, the expertise of these people cannot be restricted to 1.5 hours, because last time we have given 2 slots for Dr. Subhendhu Sarkar. Because see, this time I have specifically requested him not to go for 1 hour. So last time we have given 2 slots, 30 minutes. Anyway, we never exceeded 8 o'clock, sir. This time it had happened, but the lecture was fantastic, so we have not interfered in that. Now I request our treasurer, Dr. Hema, to propose the formal vote of thanks.
Thank you, sir. Good evening, sir. Good evening, everyone. Thank you all for participating in today's episode on the webinar in Puthukkottai Bhudhan, the topic of inotrophic support. I thank our academic chairman, Dr. A.L.M. sir, for his continuous guidance in our webinar. I thank Dr. Balaji Chenthil, postgraduate, Mahatma Gandhi Medical College, Puducherry, for your topic on factors affecting cardiac output. Thank you, doctor.
Thank you.
I thank Dr. P.S.N. Raju, sir, Chief Cardiac Anesthesiologist, Apollo Specialty Hospital, Vanagaram, Chennai. Thank you, sir. Thank you. You have given us a wonderful presentation. Thank you, sir. I thank Dr. Subhendhu Sarkar, Head of Cardiac Anesthesia, Desun Hospital and Heart Institute,